She's been in charge of pediatric education at Meharry Medical School. She's been in charge of medical legislation at the National Medical Association. She's previously been on the board of trustees of the National Medical Association. And I take great pride that she was my research associate when I was a PhD candidate years ago, actually a couple of years ago for her. I'd like to introduce Dr. Barbara Neighbor Stevens, who's the co-moderator along with me. Dr. Neighbor, would you introduce our lineup of physicians and celebrities and other guests?
Certainly, Dr. Maxey. Thank you and welcome everyone to today's program. As Dr. Maxey said, there has been a lot of news this week, especially around COVID. And I am so happy that we were able to get our first speaker engaged for today to help us sort through some of the very confusing information that is currently under discussion in the news. Our first speaker this afternoon is Dr. Vladimir Bertos, who actually was here maybe 3 weeks ago and is going to talk with us today about the new issues around vaccine administration, the announcement that was made by the incoming Biden administration that they are not going to hold back any vaccine and what all of that means for us. As a reminder to our regular attendees and new information for the first timers, Dr. Bertos is the director of the Division of Infectious Diseases and professor of medicine at Meharry Medical College. He pursued his undergraduate medical education in Haiti and then pursued graduate medical education in the United States in the New York area at Columbia and Cornell and Kingsbrook Jewish Medical Center. He is the founder and director of the Meharry Community Wellness Center, which is a Tennessee designated AIDS Center of Excellence. And Dr. Bertos holds certification in internal medicine, infectious diseases, public health, tropical health, and traveler's health. So you see, he is indeed a very appropriate person to help us today sort through the story of the COVID vaccines. Our next speakers we have a dynamic duo. We have a husband and wife team, Dr. Betty D. Walker and her husband, Professor Hildreth or Hal Walker. Dr. Betty Davis Walker is an internationally renowned educational innovator, former university professor and researcher who has worked with students in Los Angeles, Europe, West Africa, and presently South Africa. Scientist and Professor Hildreth Hal Walker Jr. led the manufacturing, testing, and operation of the CORAD K1500 Ruby laser system during the 1969 Apollo 11 moon landings lunar laser ranging experiment. This was the first experiment in history using a hand-placed extraterrestrial instrument on a celestial body. He continued his career in energy technology, focused on application of laser technology at Hughes Corporation, and later founded his own international laser systems consulting firm, TechPlus. Dr. Betty Walker and Professor Hal Walker founded the nonprofit organization African American Male Achievers Network, or AMAN, Inc., STEM International in Los Angeles. They also established the AMAN, Inc. in South Africa at the invitation of President Nelson Mandela, and implement science and technology programs in township schools across the country. AMAN Inc. is dedicated to building the leaders and participants in science and technology for tomorrow. The legacy is shared with the students and provides experiences that prepare them to attend higher education institutions and begin fulfilling the nation's leadership and technology needs. Professor Walker and Dr. Betty made history again on February 27th of 2019 in South Africa at the opening of the first chapter of the National Space Society on the African continent, the Cape Town Space Society. We welcome today a couple that have had extraordinary careers in education and science, as well as dedicated public service. Our third speaker today is the Reverend Kinzer Mark Pointer. Reverend Pointer is a Buffalo, New York native and has had a distinguished career laboring in the vineyards as pastor, civic champion in various roles, including serving one term on the Buffalo School Board. He is the founder, CEO, and president of a 65 church group known as the Greater Buffalo United Ministries, or GRUM, and safety net physicians of the Greater Buffalo United Accountable Health Work Network Collaborative, formed to deliberately decrease health disparities in Buffalo's Black and Brown communities. He later helped establish the African American Health Equity Task Force that in 2019 joined with the State University of New York at Buffalo to establish the University of Buffalo Community Health Equity Research Institute to discover and determine processes to eliminate health disparities in Buffalo by addressing the social determinants of health. Today, he will share with us his efforts in the COVID-19 Community Response Project, Erie County, New York. He is up to his eyeballs in the COVID fight, and the model that he has helped to create in the Erie County area has been used as a model by Governor Cuomo in establishing other programs across the state of New York. Our final speaker is the Reverend Dr. Harold Orr. Dr. Orr, a native of Richmond, California, received his undergraduate degree from Howard and his medical degree from University of California, San Francisco. After completion of his residency in internal medicine at Harlem Hospital, he served 2 years in the U.S. Navy Public Health Corps. His medical career includes 18 years in private practice in Oakland, as well as prison medicine and hospice responsibilities. He completed his Master's of Divinity degree from the American Baptist Seminary of West Berkeley, California, and was ordained at Allen Temple Baptist Church, Oakland, California. As you can see, we have an outstanding panel today, and we are going to open our program with Dr. Bertos. Dr. Bertos,
the floor is yours.
Okay. Good afternoon.
You know, when
Thank you for inviting me. So it's
I thought you were Russian.
No relationship whatsoever. But thanks for inviting me. It's an honor to be part of this very impressive panel of speakers today. And Dr. Maxey, thank you for laying the background with those statistics. So what do they really mean? That by the time we finish this session, around 150 to 180 people will die of coronavirus in the United States. So this is a very serious problem. And I'm going to say a few words about the vaccine. So right now we have 2 authorized, not approved, not licensed, 2 authorized vaccines in the United States. And we have a couple more around the world, one in UK, Mexico, Brazil, China, and Russia. And there are other vaccines in clinical trials. We know that those approved vaccines are safe and effective across gender, race, ethnicity, age, and comorbidities. However, we do have to recognize important knowledge gaps. Number one, those clinical trials were designed to prevent symptomatic or severe coronavirus disease. We don't know about transmission. Although the Moderna vaccine has some data about transmission, which seems encouraging, but it's not enough to make any conclusion about efficacy in preventing transmission. Number two, we don't know long-term safety and efficacy for these vaccines. We lack data among children, pregnant women, and lactating women. There are a couple of few women who became pregnant in those trials, but their number are too small to draw any significant conclusion. Although in general, when a vaccine has been approved for the general population, those vaccines are usually effective in pregnancy. The other important thing to remember is that pregnant women who develop coronavirus seems to have an increased risk for poor pregnancy outcomes. We don't know how long the immunity provided by the vaccine will last. And I know there's also a question about the number of doses, 1 versus 2 doses. And let me say up front that, for example, in the Pfizer vaccine, the vaccine was only 52% effective after 1 dose between the administration of the first dose and the second dose, only 52%. Although 1 week after administration of the second dose, it was 91% effective. To address one important topic that people have in mind right now is that should people take 1 dose because we have limited vaccine supplies now? What I would say, we cannot make any recommendation based on poor logistics. We have to make recommendations based on science. Right now, the data that's available do not support recommendation of 1 dose of the for the coronavirus vaccine. Moreover, we have to keep in mind that our goal to vaccinate people are 1, to protect the individuals, and 2, to provide herd immunity. So if people receive just 1 dose or any of those two vaccines that are available right now, they will not, or they may not develop enough immunity. As I said earlier, the Pfizer vaccine is only 52% efficacious after the first dose. So we will need a vaccine that is at least 70% efficacious if we are able to vaccinate between 50 and 70% of the population to have herd immunity. If we provide 2 doses of the vaccine, and thereby people will have about 95%, will have about 95% efficacy. We may be able to vaccinate about 70% and of the population to reach herd immunity. With a 1-dose vaccine, most probably we will not be able to reach herd immunity and we will not be able to get rid of the pandemic. That's one important caveat. The second thing is that we have other vaccines in clinical trials. We have other vaccines in phase 3 trials. So hopefully by next year, we'll have enough doses of those vaccines to vaccinate all people who need who want to get this vaccine. Another great obstacle that we're facing, as you all know, is vaccine hesitancy, which is more problematic in African Americans and communities. And that's why it's very important to do sessions like this, have a panel of different people from different backgrounds to exchange information and then pass it on to the community. This is extremely important. This is what's missing actually from the federal government plan to distribute the vaccine. There is no plan to educate the communities at all. There is no plan to reach out to people like us who are trusted voices in our communities. There is no such a plan. So as you all see, so think there's been a desire. For example, there are people that are offered the vaccine and refuse to take the vaccine. And there are people who are asking the vaccine because they want the vaccine, they need the vaccine, and cannot have access to the vaccine. So overall, we need to continue to do what we're doing here, to dig deep into the science and then to communicate the science to the people. Because once again, an educated consumer is the best consumer. So I will stop here and then I would be glad to entertain any questions. Dr. Maxi, I think you're trying to talk, but you're muted.
Well, I'm unmuted and I will start things off. Thank you so much for such an excellent review of the current state of affairs. I want to ask a question to you that I keep bringing up regarding and the distribution, the logistics and the distribution. It has been left up to the states to develop and implement their own distribution plan. Some states, like Florida, are allowing free access to appointments to receive the vaccine for anyone 65 and older, even whether or not they are state residents. States like Tennessee, which you are well aware of, have said that you have to be 75 or older to be in the first group that are eligible to receive the vaccine. How do you think this variation in the way it's being distributed is going to impact our overall effectiveness in getting rid of the pandemic ultimately?
The main reason for this variation is because of the absence of federal leadership. That's the main reason, plain and simple. The other thing that's also very important, and like I just said, it's critical to talk to the people, to talk to the community first before you design a plan. You cannot design a plan for people. You don't get them involved in the plan. You have to build this from the ground up. So you have to get the buy-in of stakeholders and of the population. So you can have strong support for this vaccine. People want the vaccine overall, believe me, people want the vaccine, but they don't trust, they don't trust the federal government, plain and simple. They don't trust the government. They want clarifications. They want to protect themselves and their loved ones. That's what people want. People believe in science. Yes, Dr. Maxi.
I want to put a question to you. I'm sorry I couldn't unmute before. I had the vaccine injection this past Monday. I had the Moderna, and as afraid as I am of needles, I took it. I didn't even feel it, and I had no side effects whatsoever, nor did anybody on my staff and family that had it. But there's a lot of information coming across the internet and that says there are major side effects affecting a lot of people. And I'm just wondering from where you sit, in terms of the 6 million people that have reportedly received the vaccine so far, both Pfizer and Moderna, is there a large percentage of side effects? And at the same time, what's the number of side effects that happen when people take aspirin?
So far, the side effects reported are less or the same as what expected from common vaccines that we administer on a regular basis, such as a flu shot. But we just started this vaccination program. So we have a long way to go. 6 million is less than 330 million people and less than 4 billion people. We still have to closely monitor the vaccinees for side effects. Yes, it's very encouraging. Myself, when I took the vaccine, I didn't feel anything. I had nothing happened after all. I felt very fine. But we still have to closely monitor. That doesn't necessarily mean that later on we may not see more severe, more serious side effects. Yes, it's encouraging right now, the way things are unfolding, the incidence of side effects, serious side effects, is minimal. So that's very encouraging. But once again, we need to use the active surveillance system, the passive surveillance systems to monitor for any other potential side effects, new side effects, or increase in severity of known side effects. And the FDA recommends the Pfizer, BioNTech, and Moderna to report on a regular basis about the side effects. So if there are any important signals, they may modify the vaccine recommendations.
Michelle, are there any questions for Dr. Bertos in the chat?
Yes, there are a few questions here. So since we're talking about side effects, I think I'll go with this one first. There's a report of an OBGYN doctor that had a stroke days after having the vaccines. Do you have any opinion on that? Maybe it was just a coincidence? What are your thoughts?
I don't know about this specific case, so I cannot make any comment about this case.
Okay.
But one, and it's small. Another thing I like to say about side effects. For example, in one of the trials, and there were 6 people with serious side effects in the vaccine group and 0 in the placebo group. So 6 out of 44,000 is very low. But because it happened only in the vaccine group, we must remain vigilant as we are upscaling this vaccination.
Okay. We have 2 more quick questions. Is it possible for a vaccine to cause antibodies to mistakenly attack the red blood cells? And if so, how likely is this?
To cause antibody?
To mistakenly attack the red blood cells.
So far, that has not been reported as a serious side effect, antibody-mediated side effect, or immunogenic, or so-called. What we've seen in a previous trial, some people reported some lymphadenopathy, like accelerated lymphadenopathy, but it's usually transient and it goes away. But in terms of immune-mediated other side effects, and we have not seen a lot of this.
Okay, and one last, any comment on the reported mutations of the virus?
Yes, so far we know about 2 very important mutated viruses, one imported from UK and the other one from South Africa, that our colleagues can tell us more about it probably. And so far, and then before I say anything, remember, COVID-19 had fooled us many times, So what we know right now, it's not necessarily the same tomorrow. Right now, what we know that this mutation does not have any serious implications in terms of disease severity. And preliminary data from Pfizer shows that the vaccine is effective against this mutated virus. But that's what we know right now. So when we collect more data, we will know better. So we cannot say the vaccine will remain fully effective against these mutations or any other subsequent mutations that could happen later on.
Okay, do we have time for one more?
Go ahead.
Yes.
Okay. Oh, great. Okay, so the Pfizer vaccine after 1 dose had up to 50% efficacy after 3 weeks, which is when the second dose is required to achieve 95% efficacy. However, after 50% is reached in 3 weeks after the first dose, does immunity continue to increase over the following weeks? For example, 60% after 4 weeks, 70% over 5 weeks. And the second dose is a booster to achieve the 95% efficacy in a shorter period of time? Or does the efficacy decrease after 3 weeks, which would necessitate the second dosage in a timely manner? That's a mouthful.
So far, the immunity after the second dose remains substantial. But we cannot say the same after the first dose. We don't know how long the immunity will last. Therefore, we don't know if people will need another vaccine dose next year. We don't know that yet.
Okay.
So we don't know the duration of the immunity conferred by either of those 2 vaccines.
Would you speak to the question of when to administer the vaccine? If some people have gone to take a a vaccine for the flu. They've taken
Yes.
shingles.
Very important questions. Now it's recommended to administer any other vaccine 14 days apart, before or after. That's the recommendation now. And also, if you had the coronavirus, you can take the vaccine. You may have to wait for 90 days, but you can take the vaccine. And before you take the vaccine, it's not recommended to test for coronavirus or to test for antibody. It appears that the natural immunity conferred by the infection is much smaller compared to the immunity conferred by the vaccine. So therefore, if you receive the vaccine after you had coronavirus disease, it's like a booster. So everyone should get the vaccine if they want it, of course.
You raised an important question to me. I had a head nurse at a local hospital emergency room here in Inglewood, and she had COVID, a very severe case, was hospitalized, went home, and she subsequently had the vaccine after that period of time. And she called me just a night ago. She was admitted septic into the hospital. She had a lactic acid level of 5. I'm concerned about whether or not a person who's had COVID can get the vaccine too soon. You mentioned 90 days, but what is the complication that could occur if they've had documented COVID and they get the vaccine soon after that?
So you may have an enhanced immune response, and you may have a magnified immune reactions. So it's recommended to wait 90 days. Normally, the other thing also that's two important points. People can get reinfected with COVID-19, but that's very rare. It's usually after 180 days, after 6 months. Okay. The second important point, if someone receives the COVID vaccine, they can get infected very soon after the first dose, and less so after the second dose. So someone may receive the COVID-19 vaccine. As a matter of fact, there have been reported cases of people who received the COVID vaccine, and then few days later, they have coronavirus. So that's also possible. So as a general rule for any vaccine, so if you had the disease, you have to wait for several weeks, months before you get the vaccine.
And my last question, I think, can you briefly talk about the long haul syndrome?
So the long haul syndrome, what they call the long haulers, are people who had coronavirus disease and continue to live with other, what I would call maybe troubling or disabling symptoms, some fatigue, weakness, maybe sometimes on and off, or fever. It looks like what they call chronic fatigue syndrome, what people get from Lyme disease. And there could be some people who also have some on and off cough, shortness of breath, and some cardiac problems as well. The pulmonary manifestations could be related to fibrosis, liver fibrosis, secondary to severe COVID pneumonia. But we do not fully understand the full spectrum of the long haul disease. We do not fully understand the specific mechanisms of all those syndromes. So this is an area of intensive research. Hopefully, we'll learn more about this particular syndrome. And associated with the long haul syndrome, also, some people also have a mental health problem, severe depression, something that look like post-traumatic stress disorder as well. So it's a full-blown spectrum of a clinical manifestation that hopefully in the next few months we will know about.
Thank you. Dr. Stevens, are there any other questions you have before the next talk?
No, we have no more questions in the chat to address. I want to thank Dr. Bertos for an excellent review of the current state of affairs, and hope that he will be available again in the near future to help us get through this maze and stay safe.
And then one more thing I would like to say, as we are doing the clinical trial for another coronavirus vaccine, one thing we learned very quickly, a lot of people who volunteer for the trial, as they have dropped because they want the real thing, they want the vaccine. So that's encouraging. that's an encouraging. It may not be good for me, but I think that's encouraging for the public. So people want the vaccine. Okay.
Just briefly, what is the project you're doing with the HBCUs?
What do you say?
What is the project you have with the historically Black universities?
Oh, we have a project in Africa that's about the HIV. So it's more specifically in Zambia and now in Malawi. We're supposed to have deployed in Malawi. Unfortunately, the coronavirus pandemic said otherwise. We cannot travel. So that's been put on hold. But we are upscaling HIV. So each HBCU college is working on a specific project, but we work together. For example, Morehouse is working on data management, and Howard is working on what they call differentiated healthcare. Meharry is working on an early diagnosis of infants and babies and pediatric HIV. And Charles Du is working with young girls and adolescents. But we work together. It's a one project. It's a very good opportunity for us, HBCU, to work together in Africa for the betterment of our for the people right now, the people in Zambia. And hopefully, when we get a chance, we'll continue in Malawi and maybe some other African countries.
Thank you so much for being one of our first line workers in research and healthcare and adding credibility to what we present to our communities. I take special pleasure in introducing
Thank you.
Hal and Betty Walker. They've been friends for a long time. They are in the nation of South Africa. They're from California, however. And I was impressed by what they told me about the way that South Africa is treating the pandemic and some of the success they've had by doing certain social things. I'd like to introduce them for a brief explanation of what they're doing in Cape Town, South Africa. Hal and Betty Walker, you have the floor.
Okay, well, thank you so much, Brother Randall, and greetings to everyone. Betty and I are so happy to be a part of the team tonight. We, of course, have been associated with the project since its inception. We arrived here last in November 2019, and have been here ever since. We had anticipated leaving to come back to Los Angeles in around April of 20, but as we know, we got stuck here with the virus and have been here ever since. But with that said, what I like to do, I'm not associated with the medical fields at all, basically, but I would like to read some statistical information because it's our interest also to make folks in the US aware of what's happening here so we can see the correlations and the needs are quite similar.
I'd like to tell them about.
Oh, but go ahead, Betty had a few comments here. Go ahead.
Yes, I'd just like to say good evening to everybody, and it's nice to see familiar faces, of course, and Randall, always nice to be involved with anything you're leading. And when we realized we were going to be here, of course, we were very concerned and interested in how things were going to proceed. And the one thing that I can say I will always appreciate is being in a Black country, Black owned country, I can say, and led by Black officials, and giving out a plan that's national, that no one can say it's not my freedom. And that's when I felt very happy and secure to be here when the president came forth announcing a plan that his health minister and COVID-19 team put together with him. And I'd like to just add that he has a master's degree from Stanford University and an honorary doctorate, I believe, from Yale. And his wife is a physician who received her degree from Harvard. So I was very confident to get to know what they were doing and how they were operating. And the first thing he did with our lockdown is said, in order for us to prepare to have the number of hospital beds and equipment needed, we need to make sure that we don't have people who are drinking and getting in accidents, taking up space for those that need the space for the virus. So he stopped the sale of alcohol. And of course, some of the people who are not African were very upset over that, but there was nothing they could do because the plan was set. So there was no sale of alcohol for 4 months. And the tobacco sales also were stopped for 3 months because of the respiratory aspects of the virus and the danger. And at the end of the first 5 month period, we had one of the lowest infection rates and deaths. And the World Health Organization sent a letter to the team acknowledging the wonderful progress that we had made. And the other thing was March, April, and May, June, July, and August start winter. March, April, and May are fall. June, July, and August is winter. And so everyone was in during that time. Now here we are in summer. And he opened up the borders. He closed down the borders. That's the other thing. So there was no travel internationally or otherwise. And when he opened up the borders after we had done so well in November 1st, so we have all of the tourists from Europe who are here now because they're leaving the 0 and 3 degrees of winter, coming to our wonderful summer temperatures. And so, of course, that new strain has shown up from Europe. And so he's now taken us back to another lockdown. And those visitors who are showing up with the virus are having to quarantine at their own expense until they can be cleared and forced to leave. So I just wanted to just point out the difference in what I see and hear from my family and from others in America of not having a plan to what a plan does and how that makes us feel very comfortable being here, even with the visitors and the increase. The curfew is now back in. You have to be home by 9 o'clock. You cannot go out until 6 in the morning. So he has no problem, and the team have no problem doing what needs to be done to try and save lives. He's trying to keep the businesses open so that the economy can come back. So therefore, 9 o'clock you go home and 6 o'clock you come out. And if you're seeing, and the beaches are closed now with all the visitors, and the beautiful beaches are now closed. And if you're seen without a mask, then you will get a ticket and you can possibly get up to 6 months in jail. So the police are all out, the helicopters are out, and they're watching to make sure that we can come through this next strain safely. Okay.
And with that, there's been, of course, a recent spike based on those conditions that have developed here in the last couple of 90 days. So I just wanted to quickly read a couple of notes. This is from the Durban area. The thresholds were breached this week after 3 consecutive days of over 20,000 daily infections, but businesses are fearful of a hard lockdown as regulations are being reassessed on Friday, this past Friday. So as Betty was saying, there's been a recent spike that is now causing some additional difficulties here. President Ramaphosa announced that the country would move to adjusted lockdown level 3, which we are presently in, effective until January 15. What's very interesting to us to compare to the US system is the fact that folk here, some recent CNN reports we saw said most Americans think that it's so very important that the economy be the priority. We're of course, the COVID-19, some secondary position. Well, the opposite is here. President Ramaphosa and the government have taken that the COVID-19 is the country's highest priority and the economy will be second. Just a little bit of something to be aware of. Some very important numbers. Presently, the total number of infections, the country's population is approximately 55 million. The present infection level is 1.2 million roughly, with approximately 32,000 deaths. And of course, the recovered, which I think is a very important factor to discuss, is there's approximately 98 to 100,000 have recovered of those infected. Which is an 80. Which is an 80%, 80.8% recovery.
80.8.
80.8%. Now, one of the things that, of course, comes up in discussions here in the country, because as well aware, there's a strong UV effect here because of the I guess that's determined from solar energy. But of course, as we know, UV does have a tendency to affect some parts of the UV spectrum are very sensitive to, the coronavirus is very sensitive to. So there's some concern that could be helpful also. But one of the things I'm sure we're all familiar with is the presence of traditional healers. And of course, traditional healers are playing a very important part now in the country's reaction to COVID-19. Traditional healers, of course, as we know, basically depend upon the herbs and the types of medicines they find historically valuable that they continue to use. And of course, there are some herbs now here in South Africa that the traditional healers are pushing, which is causing a little bit of a supply and demand problem. But anyway, but we'll have to wait and see what the traditional healer effect will be measured. No one is actually researching that.
Hal, can you speak on the vaccines a moment?
Sorry?
Your vaccine choice?
We're coming to that. That'll be the next topic. One of the things that we're doing, this is happening, of course, with no vaccine. That's what. Thank you, Randall. Now, one of the things that's happening, and Betty will be talking about the vaccine. One of the things that's, of course, a history in South Africa, similar to our history with the Tuskegee experiment in America, is they had the weaponized medicine used against them during the apartheid years. I'm sure many of you are familiar with that. And of course, that is a hesitation to a lot of folk, and of course, a barrier that's got to be overcome. I don't think we're seeing a lot of news talk about it, but certainly it lurks around in the community as a discussion. Will they try to do it again? So I think we have to be just aware that in this country, weaponized medicine has been a history here, and there's some concern about that. Now, Betty's going to give us some of the latest news about the vaccine.
Yeah. Recently, we were told that it was in the news that we were looking at the AstraZeneca that came from India. Well, now in yesterday's news, they're saying that they're looking at several companies now. Johnson & Johnson has an establishment here where they're producing a vaccine. So they are talking to Johnson & Johnson very closely now since they're right here. So they're in discussions with a couple of other companies as well to ensure that they can get the COVID vaccines to immunize 67% of the population. So the vaccines would be rolled out, of course, in the phased approach with healthcare workers and essential workers and first in line to receive it. But the plan is to have something by the beginning of the second quarter. And if they work out something sooner, we'll have something they're thinking by the end of this month or the 1st of February, based on what they can find out from Johnson & Johnson. At least 67% of South Africans will need to be vaccinated against the COVID-19 so that they can ensure herd immunity. That's what the health minister has announced yesterday. What's interesting is that the Congress of South African Trade Union, led by its president, is interested in using indigenous herbs to fight COVID. And they are calling for another look at African indigenous herbs that could be administered in addition against the COVID-19. The president has recently said, the president of the trade union has said that they feel it's important to look at voicing skepticism about the benefits of the use of Western medicines in fighting COVID-19, saying South Africa should be manufacturing its own vaccines. So as you can see here, there are many directions that they're looking at. Their herbs and their naturalized, as well as the vaccine. And whatever they decide on, they want to have 67% of the population be involved in it.
Well, Betty, thank you. And Hal, I'd like to come and be safe in South Africa. I like the way that they will put you in jail or wear a mask, or if you don't wear a mask. And, I think we Americans take too much freedom for granted. And I think that your freedom stops at the end of when your fist starts to hit my nose or do my body harm. Thank you both for joining us today, and you and Hal. Hal, make sure you say yes, dear.
Yes, dear.
Are there any
Got to do that.
in the chat box, Michelle?
No, I like that. Yes, dear. That's the key to long life. No
Well,
questions, but thank you so much for that information.
Dr.
Okay.
David Stevens,
Stay well.
you can introduce the next speaker.
All right, we are now going to move on to Reverend Pointer. And what Reverend Pointer is going to share with us is how a collaboration between local pastors and safety net or African-American physicians in the Buffalo area have effected a program necessitated by the pandemic with some remarkable results. So without further ado, I turn it over to Reverend Pointer.
Where is this poor lady? Is she?
Here we go. We see your slides, but we're not hearing you.
Is he unmuted?
Simon, is he unmuted?
There he is. Oh, there he was. There you are.
All right, good afternoon. Thank you so much. Thank you to Dr. Maxey and Dr. Neighbor-Stevens for looking at this project and considering it worthy. I think it's important for you to understand that this is not a project that we could do at the drop of a hat. This was the culmination of work that began between Black pastors, Black and Hispanic pastors, and Black and Hispanic physicians as early as 2009. We laid a framework for our working together because we realized that in Black life, there are two professionals that are present for the entire journey, and that's the pastor and the physician. And the natural alliance brought us together in late 2009. And what you're going to see is a level of work that we have been able to engage due to the fact that we had created the relationships to be able to do this. So I want to show you some data and tell you the story, and then I'd be happy to take any of your questions. On this first slide, you see a handful of the partners. Erie County Medical Center Corporation, which is the safety net hospital in Erie County, the County of Erie itself, the Buffalo Center for Health Equity, which is an outgrowth of the African American Health Equity Task Force, GBON, Greater Buffalo United Accountable Healthcare Network, which is a health home created by the safety net physicians. Jericho Road is a federally qualified health center. Endeavor is responsible for mental health services. And then partners, Goya Foods, African Heritage Food Co-op. And of course, there is private physicians also involved. So you see Ray for Family Wellness. And then finally, Greater Buffalo United Ministries. Next slide. And I want you to look closely at this data. This is the mortality case data that we were confronted with when we actually, this is a couple weeks after we began this conversation with the county executive of Erie County. We began that conversation on March 8th. New York went to New York pause on the 15th, and this was the stark data on April 2nd. This is the county's data. I want you to also take a note of what the county does not show us in this data, because we changed the way they were disseminating data. If you look at this chart closely, cases by race, you see percentages of overall cases and then percentages of deceased cases by race. You move down to Black or African American, we are 35% of the cases overall, 40% of the deaths. We are 14.7% of the population of Erie County. Look at Caucasian cases, and you see it's reported as 25% in a county where they're about 83% of the population. You'll see further down, there's a designation called unknown. We looked at that and we said to the county executive, look, we don't have time to game for gamesmanship. We want real statistical data based on ethnic and social groupings. Let's just tell people the truth so that people can do what they need to do. So you're looking at the July 14th data, which is a change in the way the county was reporting data. We implemented our project on the 5th of May. You can already start to see a decrease in fatalities amongst African Americans in this data. What we did on May 5th was we implemented a COVID response project throughout the community to do health education amongst people, to give them access to health care by enrolling them in primary care using New York State of Health. We encourage people to stay in their own neighborhood to seek the care they need. We also caused the county through the medical center to ramp up testing in the region. So we began in April with 4 places in Erie County you could get tested. We ramped that up to 135 places throughout the county so that everyone could simply be tested in their neighborhood. No one had to get on public transportation to go to receive a test. You could actually walk in your neighborhood and get tested. That kept people from traveling, which really is important when you're trying to mute the spread of a pathogen. Next slide. All right, this is our data as of Friday. This is scary data for us because we were in yellow for months, and we're now in orange in Erie County. We're not concerned about this data in the communities that Black and brown people live in because the spread isn't taking place in our community. The county executive in quiet conversations with us have indicated that the spread is outside of Buffalo and the rise is outside of Buffalo while the city is relatively stable. That's because we've done a robust program of health education. 42% of the people who live in Buffalo don't have transportation. We're providing transportation to medical and for other necessary and essential travel. Additionally, we are delivering to people in their homes fresh fruit and vegetables, dry legumes, long grain rice, and spices so that people could actually stay at home. They don't have to go out to grocery shop. We set up 25 call centers in our churches in Buffalo and Lackawanna. And we've called Erie County residents all over the county using the county's voter registration database, which has about 700,000 people in it. And Erie County has a population, Erie County itself has a population of 980,000 people. The city of Buffalo, there are 270,000 people, and the metropolitan area has a population of about 2.7 million people. But the metropolitan area for Erie County is actually 8 counties. So it's not a lot of people in an 8-county geographic region. But this spread that you're looking at, these confirmed cases and deaths are not negatively impacting us in the way they were in April. Next slide. On this next slide, I want to show you, on these next few slides, I want to show you some of the things we did around the health education piece, because we want to educate people regarding the social determinants of health so that they can make informed decisions. So in our questionnaires to them on the telephone, we ask about the social determinants of health. What's your living situation? What's your food? Do you have transportation? What's the educational situation in your community? And those questions become really important because they focus people to start thinking about those things, and they're not thinking. We asked 4 questionnaires in the conversation. We trained our young people to be really skilled at telephone interviewing. Next slide. We asked, most clinicians will recognize the next slide because it is patient health questionnaire number 9, which is a brief mental health survey. What we knew immediately upon implementing this project is that in the African American community and in the Latinx community also, we don't seek mental health treatment. But I knew immediately that when you talk about people being isolated, that would exacerbate any mental aberrations that already exist and may or may not be treated. Because whenever you isolate human beings, you are going to cause a rise in the kind of anxieties that people almost always deal with as they're moving about in society. So we asked the patient health questionnaire 9 to every person that we talk to, and we refer them. They are automatically referred at a score of 15, but also gave the specialists who are calling on the phone, I gave them mental health first aid training so that they could become more skilled at recognizing when something isn't right. Because they were already reporting to me, they were saying, Pastor, I did the PHQ-9, they scored a 4, but I'm not comfortable. I think based on my conversation with them, there's something more going on. So we reached out to Endeavor and had a Zoom conversation, much like we're doing today, and said we'd like to do direct referrals based not on the PHQ-9, but on human-to-human intuition. And they accepted that. And we were able to refer 127 people, 107 of whom were suffering from behavioral health issues without ever being assessed or diagnosed. And so 107 people today are getting the kind of therapeutic care they need because we were able to go outside of this questionnaire. Next slide. All right, this, of course, is the earliest version of the health education around COVID-19 on the CDC website. I thought it was important to educate the young people in the call centers so that they would know what COVID-19 was and so that they could ask questions. And because, of course, we're serving both Latinx and African-American communities, we thought it was important to use both languages. Next slide. All right. This is more recent data. This data is important because I want you to know, we typed it in here. Today, in this time frame, we've been able to mute African-American COVID-19 deaths in Erie County. They are now standing at just almost equal to population. And look at the basic breakdown along gender, because we want people to understand that this is important. And then look at what's going on with our Latino brothers and sisters. There, for Dr. Raul Vasquez, who leads GBON and whose practice has about 30,000 patients, he's reported 1 death in the pandemic with 30,000 patients. And Dr. Vasquez is one of those guys who's hand-on. He was my early partner in establishing the collaboration with safety net physicians and pastors. Next slide. Now look at this chart from September 22nd. I wanted to give you a close side-by-side comparison. You look at African-American fatalities, still about 2 points higher than the population. Although our in the Hispanic community, it's been pretty steady. But as you can see, there is an intentional desire to end deaths in our community. I just really, as pastors, we just really weary of standing over funeral buyers for persons who are dying because of the comorbidities that are rapidly associated with the worst outcomes in this pandemic. And we were able to do this because while the president was lying, we were looking at the data out of Europe. And we knew, based on what we saw out of Italy and Spain, that if we didn't do something, we were going to be in serious trouble. And so that's how we began the conversation with the county executive. Now, let me tell you about how the economics have worked. Erie County Medical Center gave us $1,125,000 in May. We implemented this project with that $1,125,000 in May. We concentrated heavily on the most disparate zip codes in the city of Buffalo. We made just under 100,000 phone calls to the residents of the city. We educated people, we talked to people. We even went back and checked in on people to see how they were doing. Because one of the things that the specialists in the call centers pointed out to me very early was that a large number of people were quarantining, but they were lonely and they were starting to suffer from low-grade depression. I think Michelle Obama highlighted that for us best earlier this year, or late last year when she talked about it. Forgive me, I'm still in 2020. But we thought this was important for us to do. Our money was scheduled to run out at the end of August. At the end of July, the county executive called me. He said, remember when you told me you didn't want any money? Nobody ever tells me that. So I simply have stood by and watched what you all have done. And I want you to know I'm going to use CARES Act dollars to fund you to the end of the year. So he gave us, he said, I have two requests. One, reach out into Greater Erie County. And two, spend all the money. I told him the first one, we'll have to figure that out. And the second one, we can do without a whole lot of thought. But we were able to figure it out. So we reached out in the Greater Erie County. He gave us $2,700,000. We reached out from 18 zip codes. We reached out to 105. Today, we've made over 400,000 phone calls. We are actually still running. The CARES Act money ran out on the 30th of December, but the county executive is committed to funding us month to month. So he's giving us just a shade under $700,000 per month. And at this point, he's scheduled to do that through April. Next slide. These are our latest fatalities. I want you to know that as of this week, these are this week's statistics by Erie County. You don't see the percentages for white and Black deaths, but Black deaths stand at 14.7%. And I think that's important. Hispanic deaths stand at 2.2% of the overall total. I think it's important because I don't know if there's another community that has done this in the nation. We set out to do this deliberately. And we've used public dollars at every turn to do this because we had created the kind of relationships that we could be trusted to administer this project with public dollars. The pass-through is one of our local churches that has a community development corporation. And the work that we're doing is still important to do in the city of Buffalo, but we've reached out in the Greater Erie County. We're continuing to call. I just added 250,000 households to the performance database, and we're still continuing to make those phone calls. I think this is a project that can be replicated anywhere. The governor noted what we were doing, and he at least partially replicated this in Brooklyn and the Bronx when they were just really getting slammed. Next slide. I think it's important for us to have the ability to talk to each other. So, next slide. Did I miss? All right, there you go. So I'm going to give all of you my contact information. The slides, Dr. Nabrit and Dr. Maxey, you can share them. They're not proprietary. The important thing is to keep African Americans and Latinos from dying across the country. What you didn't see in the data was that I was able to use vendors who look like the community. Food deliveries were done by if you can return to page 1, it'll give you a better idea. Food deliveries were done to people's homes. People didn't have to go anywhere. They were non-contact deliveries that we did to their homes. Those deliveries were done by African Heritage Food Co-op. African Heritage has been stood up to be a stronger organization based on this project. I also use Goya Foods. Some people argued about that, but you know what I said to them? I don't care what the president of Goya Foods is talking about. I've been to Goya Foods Great Lakes, and everybody in the plant and in the distribution center look like we do. So I'm not going to, in a knee-jerk reaction, spend more dollars to feed the same number of people, because you can't do it that way. You can't feed more people with the same number of dollars. So I ignored that noise, because that's what that was. And what the president of Goya said about the current president, that was noise. I ignored that too. You've got to stay focused on what God has given you to work on. So having said that, I am pleased to have been here to present. I've enjoyed the Black Health Trust. I was introduced by Dr. Stephen Thomas. And if any of you need me for anything, please don't hesitate to call. As up to my eyeballs as I am, I can still see. Thank you. I'll be happy to take questions.
Well, I'll start things off as people gather their thoughts. What would you say to anyone who is motivated by what they've heard and want to try to make some impact in their community? What would you say are your lessons learned?
You've got to talk to everybody. You can't afford to isolate yourself in your own community. You've got to talk to everybody who wants to talk to you, and you got to talk to people who didn't know they wanted to talk to you. You got to knock on doors that you haven't been invited to, and you've got to have frank conversations that people don't want to hear. You got to tell people the truth at every turn, and then you have to challenge them to live with the truth, and then just let's work together to create a different truth.
And then I was curious, I'm sure you've done some kind of satisfaction survey, a collection of data. Outside of the dramatic data that you have, what did the actual recipients of the service have to say about it?
Well, I keep getting notes and letters from people who've been served. Now they're calling the county executive to tell him that they're pleased, which is really good, because I just asked him for money for the first time. And whenever you ask politicians for money, you need the community has to be behind you in order for them to give you money. So I'm thrilled to death that they're calling the county executive. But the satisfaction is wide. In the 8 months we've operated, I've fielded about 5 complaints. And as I said to you earlier, we have made almost 400,000 calls.
Fantastic.
And we're keeping data on everything because everybody here knows data is king.
Well, Pastor, it's been our honor to be able to talk with you. And as you know, we are inviting you to meet with our board of directors. And
Looking forward to it.
we're definitely interested in working with you to emulate some of the things that you have done to help our community. And we hope other people will take heed of some of the things that you've said. We thank you for your contact information. We're going to make it available on our website. And if there are any questions, Michelle, anything in the chat box?
Yes, there are some things in the chat box. What recommendations would you offer, Reverend, for those who want to develop those relationships with local officials?
Get beyond the partisan labels. That's the first thing you need to do. Forget about who's a Democrat and who's a Republican. Just talk to people about people. That's the first thing you need to do. And look, these are people that are supposed to serve the community that they've been elected by. Remind them of that and let them know, and then, take with you other people who don't mind, rattling cages, because that you're going to have to do some of that. But you've got to get over the Democratic Republican thing and just talk about people and talk about human concerns and human conditions, because everybody understands that. Even when their ideology is stupid, their humanity is usually intact.
Okay, thank you. And so I agree with you about looking for vendors, whether vendors or practitioners, medical practitioners in our own communities. So is there any recommendation for finding such vendors or medical practitioners in one's community? Is there a centralized aspect of things where people can go to say, who's in my area, who's in my community that I can use for fresh fruit and vegetables, who's in my area for medical advice, especially people who may not be computer savvy, how are they getting that information?
The medical is easy. The local chapter of the National Medical Association, you'll find all of the Black physicians. At least you'll find the ones who are smart enough to know they should be in the NMA. And once you contact the NMA, you'll have a wealth of other information. And then look, as pastors, we know where everybody is. So you come to me as a pastor in this region, and I can tell you where everybody is located. That's how I was able to, of the $4.8 million that I've spent in this project, I have spent less than $100,000 with vendors who don't look like us, intentionally.
Very good. Thank you.
I hope that you can stay because
I'm staying.
Ready to move to. Thank you.
I ain't going nowhere.
Moving to our next speaker.
Excellent.
And the two of you, I think, together are going to generate some additional questions. So, Dr. Orr, are you on?
I saw Dr. Orr. He's here.
All right. Without further ado, we're going to move on to the Reverend Dr. Orr.
Can I add a little bit of ado before we move on?
A little bit.
A little bit. Dr. Orr, I had the privilege of being a senior resident when he was a resident. He was one of our most outstanding physicians at Columbia University, Harlem Hospital. And I was extremely excited when I found out that he was also a pastor and a reverend and a minister of God. And I certainly appreciate him accepting the invitation to join us. Pastor Dr. Orr.
Thank you so much, Randall, Dr. Maxey, and those of you who are gathered, strangers to me in name, but not in concept of what it is that you're trying to do. I am really thrilled by the data I just saw. That reduction in African-American death from 40-some-odd% down to 14%, that's real. And that means you're saving lives. And that is significant. If nothing else, the walkways, if nothing else, there's something they're doing that's working. And I'm one of these people that I don't believe you have to reinvent the wheel. If somebody's got something going, it works, it can work in my community as well. So I'm definitely going to reach out and get some data to try to see what impact we can have here up in Northern California. We have a group called One Accord. It just started really the past couple of months, made up mainly of pastors. And there is no central group or organization that get the various denominations together. So they're coming together and trying to meet around this whole pandemic. If Southern California is challenged by a rage of this pandemic that's out of control, we have ours is at least twice as high as it was 2 months ago. But some of the secondary effects we're seeing up in Northern California: homelessness, out of control; mental health issues, out of control; drug and alcohol issues, out of control, as a result of what the pandemic has done. And so trying to organize, trying to come up with something that will have impact. To me, this is all about God having me here on this day to hear what Pointer had to say, because he has implanted some concepts in my mind, and I certainly will be in touch to get some cleaner ideas about how to approach it. Now, granted, he had a group that started back in 2009, and they had something, organization together, which is great, but you got to start somewhere. You have to start somewhere. I think I threw a few slides together. They're very simplistic. No? Anyway, it's not important. It's not important. It's not important. The thing that I wanted to talk about, being a physician and being a pastor does give me a unique kind of situation. And when the thing first started, I reached out to a lot of the pastors in my neighborhood who I know who were driven to have people in those churches to stop having church service. And trust me, it was a battle. But I had to lead by example. And so I closed my church down in early February to, yeah, there you go. And made myself available to talk to different pastors who 99% of them knew nothing much about medicine, didn't know much about this pandemic. And that's the last slide, actually, or towards the bottom. Keep going up, keep going up. There you go, start right there. So education is critical. Educating the stakeholders of your community, critical. They got to know, because people are going to come to them with questions. People are going to come to them for insight and answers. So the big issue, what I started in my little church was, after services, I have a question and answer period. And a lot of the questions the issues that you've talked about have come up about, being not sure, how do they develop so quickly? How did this happen? And being able to answer these questions. And I've watched the questions change in their sophistication as people have gotten more knowledge about what COVID-19 is about. So education is absolutely critical. From the pulpit, when I step down out of the pulpit, we're doing a free conference call, and we're doing Zoom simultaneous on 2 platforms. So it gives that interaction that I can have to help educate people. So when I just look at this slide, that's the answer to me. That's the answer. That little vial has the vaccine in it. I think it's about five. I think it's 5 doses per vial, maybe 10. I think it's 5 doses per vial. I'm getting ready to have mine on Tuesday. Now that is a big point, because my church member said, "Okay, doc, when you get your shot, then I will consider getting a shot." Now here's my challenge. I can't just go up in there and get a shot. Walk up in this place, get a shot, and go home. I gotta film it, show it, talk to them as I'm getting it, to let them know that I'm getting the real vaccine. This is not salt water going in my arm. This is the real vaccine that I'm taking, to convince them. Now, that's not going to convince everybody, but it will convince a few more. When you begin to commit, it becomes exponential. You begin to show, well, my pastor did, and he's a doctor, and he did, and the word begins to spread. More and more people will likely join. Go to the next slide. This is something that was really important to me. Because some of the first questions, well, how did they develop it? Doc, how did they do this so quickly? And then what was important to me was that how many of us were involved in the trials? Did anybody in my church, did anybody ever call and ask you, would you like to be a part of this trial? Have any of you on this phone call, anybody call and ask you, would you like to be a trial? So then we're 13+% of the population, but it was about between 9 and 10% of the people were part of the trial. We've got to do a better job of being represented in significant studies that impact our health. And if it's, it may have to be being involved with the drug companies that are doing it to make sure that the researchers are doing enough to get out into our communities to invite us into the studies so that when things are done, they can earnestly say here's what happened in the Black American community. No different or significantly different, whatever. But so they don't extrapolate. Don't leave us out. Don't leave us out, because when we're not included, that just raises the level of uncertainty amongst our population. Critical, I think, in terms of research populations. Next slide. The process that took normally 10 to 50 was completed in 1 year. Said, how did they do that? That was a question everybody was asking. How did they do that? It's an entirely different thought process of making a vaccine. Randall will tell you that most vaccines, they would take a virus, they would take a piece of the virus, an attenuated virus, or they would kill the virus, and they would be trying to develop a vaccine this way. Someone got the brilliant idea, and I think that God probably delivered to somebody in the middle of the night to say, you're going on the wrong letter. Take it to a DNA molecular level. It sounds fancy stuff, but it was an entirely different approach to creating a vaccine. And when it did, it opened the door. Let me tell you something. It is more than just COVID-19. In this CRISPR, it's called CRISPR technology, there are answers. There's been at least one case, maybe two now, of curing sickle cell, not treating sickle cell, curing sickle cell. Do you understand the difference between treatment and curing? You know, doctors, we treat all kinds of stuff. Jesus cures people. And this new technology is opening a door to a whole different possibility of actual cures of DNA or genetic disorders. Many of them the thalassemia, blood disorders, sickle cell, all these kind of things. So this is just one pathway that they're using this new technology. Next slide. I'm starting to sound more like a doctor than I'm a pastor now. Next slide. Now, this is, somebody said, Doc, just think about this. What's worse, the vaccine or the COVID infection? I told my church this last week. Think about it. What's worse, getting the vaccine or the COVID infection? Vaccine, first shot, maybe a little sore arm. You know, there have been, the doctor was on the first thing, when I first came on, was talking about some of the side effects. And what happened in the European study, what happened, there were 6 people that had some significant reaction. There were 2 who had significant reaction because they were hypersensitive and they were peanut allergies, and they walked around with the EpiPen, and they were going to react to anything. But of the 6 people, 4 of the people of those 6 were in the group that did not get the vaccine. Only 2 of the 6 were in the vaccine group that had some significant illness. So from the information, you guys were asking some great questions about like the first dose thing. The reason they can't answer that question, they just don't have the data yet. No one is, Fauci came out and said, well, let's just try one dose vaccine and see what happens. Well, why you want to do that if the 2 doses, you'll get 95%? I'm not willing to do that. Maybe sometime down the road you might want to do that in a group. But right now, if 2 gives me 95 and 1 gives me 50 or 60, I want the 95. And so we don't have that data that the 1 in 3 weeks will be 50%. Maybe it will be 70% and forward. Nobody has that data, but I think that eventually it will come to fruition. So what's worse? That's what I tell my church. What's worse, the vaccination of the COVID. You've all had that. We all remember when we were younger, we had that little polio vaccine. We had that little sugar cube. We all took a salt vaccine. We've all, the MMR that your kids get and things like that. We've all, had that. And the infection far outweighs anything that you're going to get from the vaccination. Next slide. Here are side issues that we don't think about. Stress and anxiety, worry and loneliness, but people being shut down and shut in. People are used to, especially the senior population, used to going to seniors' place, playing a little pool or just interacting with people, not able to do that. Everything begins to close in. Depression, clinical situational depression happens. Separation anxieties happen. Post-traumatic stress. This is a very stressful situation. Friday, I had a patient, 92-year-old. I do hospice care now, hospice care. I had a 92-year-old woman who was has dementia, and she's COVID positive. You would have thought I was going into a room full of bacteria, but I was double gowned, double gloved, mask, shield, right? Concerned about my getting infected, bringing it home to my wife and family. So it's a stressful thing to deal with and handling with. People, the finances, the economy's down. You're not going to fix the economy until you fix this COVID thing. You're not going to fix the economy until this COVID thing gets straight. Trying to fix the economy after COVID is ridiculous. Once the COVID thing gets under control, you'll be able to, the financial things will turn. Boredom and frustration. I can't tell you how many calls of people I talk with who are just, that's why people feel fed up with, I don't want a WMD, the washing your hands, masking and distancing. They were tired of it. They couldn't stand it. They were still frustrated. And just worrying about the infection. Not to even think of the next slide. Substance abuse, drugs, alcohol, pills. People are turning to anything to try to deal with this situation. Here's something, you can't see it. You can't see this virus. You can't taste it. You can't smell it. All of a sudden, you're just sick and about to die. Next slide. Well, we talked about the homelessness. I tell you, Northern California, the thing that really worries me as I see this, I've never seen it like this. You can't drive down a freeway overpass and not see people camped out. You can't, the little parks and little hilly areas, people are camped out. And the thing that really bothers me, we have a homeless ministry at my church, and the kids are there. The kids living in these tents, out in the weather, out in the rain, because their dad or mom lost their job and they lost their homes. Hunger. We have a feeding program. And I was listening to Porter's presentation about getting food to people. People who were once never thought that, you saw those pictures of people in Texas, people in LA, cars lined up. People are hungry. We've got to do something to address that. Next slide. Here's the thing that gets me. This came to me last night, so I know the Lord was dealing with me last night. Here's the number. COVID deaths, 375,000. Vaccination deaths, 0. 375,000 deaths from COVID, vaccination deaths, 0. Oh, there have been some illnesses. There have been some Bell's palsy and the people who have allergy that, but they were quickly reversed by giving them EpiPen. This is what I tell the church this morning. I said, look at this number. What are you going to do? Go to the left or go to the right? There's no comparison. No comparison. I know our history. I know what happened in Mississippi. I know what happened in North Carolina. I know what happened in New York. I know all those stories. But this we've got to focus on. This, we can't test our way out of this thing. We just can't. This vaccine is an answer. And the other vaccine, the two are an answer. Next slide. That's a good number. That's a real good number. This is just the end. You know, when I was talking to the church, I said, you know, if we believe, somebody said, well, you know, where's it come? I said, you know, God is omniscient. He knows it all. He knows everything that's going on. And I said, if you believe in him, you have faith and trust in him, you're going to see the glory of God. You know, I wasn't worried about number 45. I really wasn't. I knew God was going to expose him and take care of him. I really was not concerned. And that's exactly what he does. And then in the second Chronicles says, if we don't know what to do, but our eyes are on you. When I am in my fit of destruction and despair, my eyes are on God. And our eyes should be on God. We got the answer. I know we got some work to do. I know I've got to get these pastors to talk to their congregations. You know, God has taken us out of the church. Got us on the social, he got us on Zoom and freak out. He's got us bringing his word in a different way. We actually reach more people. Got people in Africa coming, Barbados, New York. I'm out in Richmond, California, and people are coming to hear the word. So it's an opportunity. So this thing, is as trying as it is, as difficult as it seems to be, you know, I know that there's an answer. Just one quick point, one little last point. Randall, you remember when we were training back in Harlem Hospital, there were those senior citizens who had survived the 1918 epidemic. Remember that? They had the post-influenza syndrome, you know? Are we going to see that? Now, we don't know, but I suspect these people that they call the long haulers and these that have these long-term sequelae. It wouldn't surprise me that 20, 30 years from now, you're going to see people developing long-term consequences of this vaccine, which is of this influenza, which is of this COVID-19, which is why we need to get treatment and protect ourselves. And so the final question of my church was, what are you going to do? What are you going to do? What are you going to do? Are you going to sit, or are you going to act proactively and have something done about this COVID-19? And I guess the very last thing would be, you know, I don't know about you, Randall, where is influenza B? Where's the flu? What's happened with the flu? You know, everybody's concerned about having both COVID and influenza. What happened to it? Is this virus so tough that it's kicking influenza to the side? What's going on? Why does one person get it and the next person doesn't? I mean, what are these things? So anyway, these are the questions as a small-time pastor and physician that I have. And Randall, I'm so glad that you invited me to this, and I'm glad that I've gotten to hear Reverend Pointer, and I'm certainly going to be reaching out to him to get some additional information, because it's here. The information is here, and God bless each and every one of you, and talk to you when I talk to you.
Thank you so much, Reverend Orr.
I'm sure glad that you accepted the invitation. You forgot to say one thing, Dr. Orr.
What?
Give your right hand to me and your other hand to God. So
That's always. I
certainly appreciate your information and your spirit of what's going on. Michelle, are there any questions in the chat box for Dr. Orr?
Let's take a look at.
It's actually a question also for Reverend Pointer.
Okay. Please address, do you want to do the first one? Please address the use of targeted testing to inform vaccination strategies.
Okay. Targeted testing means you're trying to find out where is the infection. You know, is it, if you've got a few cases coming in and I don't know, in East LA or something like that, are you going to intensify your testing there to see the spread of the disease or the epidemiology of the disease in a particular neighborhood? But that gives you information, doesn't stop the disease. It'll tell you, yes, there's a problem. We need to be more intensive with I call it WMD. We need to be more intensive with washing our hands, more intensive with wearing masks, more intensive with social distancing. But it doesn't take the disease away. The vaccine in the right numbers changes the whole ballgame.
Okay, and then if we can answer this, please share your challenge questions of the vaccine administrators to confirm its validity. For instance, that it's not salt water.
At some point, you know, this is last week, I said, you just gotta trust me. You gotta trust me. And I said, here's my wife, she's gonna take it at the same time. You have to trust that I am not trying to deceive you. And I don't want to. I don't want to sit and take some salt water in my arm. I want the vaccine. Salt water is not gonna kill me. Getting that virus will. So I'm not gonna let nobody put me salt water. You put the salt water over here. Over here, I want the vaccine. So it is, I understand the misgivings that we have, because we have been abused. You know, Trump 45, I think it was in April or May, he found out that Black people were disproportionately dying from this illness, and he backed off it completely. He backed off completely when he got a good way to get rid of. I ain't got to worry about, let that virus take them out of here. So I understand our misgivings, you know, but at the same time, when we know, and I truly believe, you know, Randall's the same way. Randall's a scientist. Randall's a great scientist. We're scientists, and I'm going to trust the numbers of science, and I'm just going to work hard to convince the people, the pastors, the key stakeholders in my community, the politicians, that this is what we need to be concentrating on. Yes, we got to keep washing our hands. Yes, we got to wear a mask. Yes, we got to social distance, but I want that vaccine too.
Thank you so much, Dr. Orr.
Michelle, are there any other audience? I want to do something, again, a little bit abnormal. I noticed several outstanding health practitioners on the line, but there's a very well-known kidney specialist from Miami who's one of the tops in her field. And she's a professor, full professor at University of Miami. And I wonder if she has a comment or a question of the speaker. And I also noticed that one of the members of Dr. Orr's church, who's an outstanding psychiatrist in the San Francisco area, is also on the line. And the president of the Charles Drew Medical Society is online. I'm wondering if those individuals would like a very brief comment or question. I saw Dr. Dolly Green. Dr. Clark.
I think they're trying to get unmuted.
Simon, can you unmute them? Into?
Okay, thank you. Good afternoon.
Good afternoon, Dr. Clark. Nice to see you.
Good to be seen and not viewed. I'm very glad to be here, and thank you for calling me out, Randall. The only thing I have to say that's different from what has been said is that I got the vaccine because I'm still practicing in my county and still doing direct service. Contra Costa County offered the Moderna vaccine. So I got my first injection about 10 days ago, and I'm due for my second one on the 21st. I feel very strongly, and I've worked with members of my family who were resistant to the point of being delusional about receiving the vaccine. We must constantly redouble our efforts to make sure that our people are protected, that everyone is protected, but particularly our people who are so resistant for good reason and good cause to receiving the vaccine. So thank you very much. And also continue to pray, because we got a whole lot of other stuff coming at us and a potential civil war that we all have to contend with. Thank you.
Thank you very much. Is Dr. Goffney, the president of the Charles Drew Medical Society? Okay. I had something come to me. Somebody referred me. I'm going to ask our two remaining speakers to maybe comment on it. Drs. Pointer and Drs. Orr. It's Isaiah 26:20. I'm trying to be impressive, okay? It says, "Go home, my people, and lock your doors. Hide yourselves for a little while until the Lord's anger has passed." I'd like your comment or interpretation if that's any way relevant to the advice that we're receiving. Dr. Orr, Dr. Pointer?
Dr. Maxey, I always shrink from taking biblical texts and applying them in such a disconnected manner, because that particular text is written to a particular people at a particular time and place in a particular circumstance. And without giving you all of the background, it would be absolutely irresponsible for me to draw analogies to the present day. I'd have to lay that all out for you, and you've already used 2 hours of these people's time.
Well,
Yeah,
thank you, sir.
Randall, and when you in seminary, you're taught, and Pointer's right, you're taught to exegete a text.
Yes.
And you just can't take a text and create a religion. I mean, you got to read before, you got to read after, read, the chapter before, and find out what it's about for that particular reason, because we know the Bible is inerrant. We know for that particular situation, it's a very appropriate scripture. But to take it and try to apply it to what we're dealing with, that would be, I can name a couple of pastors that would probably do something like that, but that would be pulpit malpractice.
It would be
pulpit malpractice.
I stand disciplined and corrected. Are there any questions in the chat box?
No, we can go ahead and proceed to wrap up.
Well, very good. I certainly appreciate our distinguished panelists for speaking. And we're just about at the time when we need to get off. We're actually 5 minutes over. But I do believe and received advice that we need to listen to the people. And we're going to have the ability to do that as of February 1st. We have a new website and web presence that will allow people to interact with us. We have our own platform where we can stream live, not only on Facebook and LinkedIn and YouTube, et cetera, but it will allow us to have direct communication. We can do surveys, people can put questions in, we can interact more. And we want you to like us on the chat boxes, another place where you can put the thumbs up symbol. But we want to know if we're doing a good job and what we can bring you in terms of information. I appreciate the fact that we've had such outstanding speakers today. We're going to be back to you next week. We will have a medical advisory meeting this week. We're going to talk about regenerative medicine and stem cells and the treatment of COVID, among other things. So we invite our licensed physicians and practitioners to join us on Wednesday. Dr. Neighbor-Stevens, any comments now?
I think that this has been a very informative program today. And what particularly resonates with me is that Dr. Pointer, Reverend Pointer, is showing us an action plan. And there are many people that are interested in reaching out to you. There's a question about whether or not you have a website. Michelle, if you could put the email back in the chat box one more time for those who want to reach out to him. And we look forward to working with you. And I hope that today's program has met and spoken to many of the people in our audience.
And we thank you for joining us. And please look at our website at blackhealthtrust.org. It will be fully functional. It's functional now, but it'll be fully functional as of February the 1st. We thank you for your time. Have a great day, everybody.
Thank you, everyone. Take care out there.
Bye.
Thanks, Simon.
Bye.